Hello. I'm back again. I started to walk away and start my day and said, you know what, I got a little addendum. I just want to add to my other morning coffee for a second. And that's I wanted to talk about my consulting website and information up there. Because if you don't know about it, it's got some useful information. Two areas in particular, the attorney section. Uh, that's There's some handouts up there that you might find helpful. One is just a description of the pathology. So you can hand that out like candy, just a description of the pathology. The A second one is the risk assessment handout that in all cases of a dangerous pathology, that's suicide, homicide, and abuse, child abuse, spousal abuse, elder abuse, mental health professionals are required to do a proper risk assessment or ensure that one gets done. So think about suicide. If a person says they're suicidal, we are obligated to do a proper risk assessment for possible suicide or get them to an ER to make sure one gets done. We're not allowed to just walk away. With child abuse, there are four diagnoses of child abuse in the DSM: physical, sexual, neglect, psychological. The first three are mandated reports to CPS to get their professionals to do the risk assessment. So there's no choice in those. For psychological child abuse is not a mandated report because it's too complex for CPS. That's above their training, which allows then the mental health professional to do the proper risk assessment or make sure one gets done by somebody who is competent. But they're not allowed to simply disregard child psychological abuse. They have to do a proper assessment for it. And then we also have spousal abuse, possible spousal abuse psychologically using the child as a weapon. So they got two dangerous pathologies that they need to do a proper risk assessment um, on in this situation. So that risk assessment handout speaks to that issue. In all cases of attachment pathology, all cases of severe attachment pathology, a proper risk assessment for possible child abuse needs to be conducted to the appropriate differential diagnosis for each parent. Is the targeted parent abusing the child, creating the child's attachment pathology towards that parent, two-person attribution of causality? Or is the allied parent psychologically abusing the child by creating a shared persecutory delusion and a false attachment pathology, an artificially created attachment pathology in the child for secondary gain of manipulating the court's decisions surrounding child custody? So those two handouts could potentially be helpful to you. The Then I also have my specialized domains of expertise, if that's for the attorneys when introducing me or doing something. So there's a handout about where my six domains of relevant specialized expertise and where they are in my vita and what the support is for those, for qualifying me in. But then the other handout that might be helpful to you is one on um, professional to professional consultation, so second opinion to people, and it goes through a variety of kind of a menu of if a mental health professional wants to consult with me. One of the primary ways is I got booklets. That's easy. So just you want an assessment, you say here, there's an assessment book. Again, this is educating people and educating the court about what's happening. And so you can provide them with the various booklets I have: narcissistic parent, contingent visitation schedule, all the booklets. So you can provide those to the mental health professional, or you can ask, or they can consult with me on a one-time basis, and I can kind of fill them in on the pathology. We can do ongoing, some sort of consultation to help them out with treatment or something, all the way up to actually me being a second opinion in the assessment session. Through telehealth, that's what it's designed for. I personally believe that that's what we should be moving towards for the court-involved psychology, is we should be getting a second opinion through telehealth on pretty much every case, because it's going to be a disputed diagnosis. The um, appellate system for disputed diagnosis in healthcare is second opinion. You don't litigate, a disagreement about autism. You get a second opinion. Is this autism? So is this child abuse? It's going to be a disputed diagnosis by one person or the other. Let's get a second opinion in from the start and reassure the court that that's a solid diagnosis. We can get three opinions. They can appoint their own expert. We can have a three-doctor appellate panel that could provide the court with a really good report. So those are some informational handouts on my website. The consulting, Dr. Childress-consulting.org. It has gold trees. My other website has purple trees. It's like an archive of information at this point. The other domain that you will potentially want to look at is the mental health consultation area of my website. When I had a consult with a forensic custody evaluator, I provided them with a link to my mental health consultation website, which provides them with information that they should have at a professional level and kind of orients them to their obligations in the situation. And so that consulting website has resources that I would suggest that you take a look at and see how you can use. One of the issues is I'm one guy, semi-retired at this point, just doing consulting. I have a life in addition to my work in the courts, and I'm just one guy, and I'm old, and I'm going to be leaving the planet at some point. And so the issue is empowering you, all of you, to be able to access the services and leverage the professional quality of services that you need, rather than just the few that I work with. Now, getting me is nice, and I can do a lot of stuff, but I'm also a little pricey. I'm an expert in this stuff, and you're calling in the big guns and the big hammer on this. But we don't need to do this in every single case. What we need to do is have the same exact messaging, so that my messaging from Dr. Childress at my level, that's going in and being read by the courts and going in as support for licensing board complaints, or just a forensic evaluator looks at my report and stuff. So that education and that power is on the same messaging as what you individual parents are doing as well. So the shared delusional disorder, factitious disorder, child psychological abuse, spousal abuse, and you got solid information on that, and you're improving the quality of mental health services in the field. That's another argument I have with the Gardnerian PAS people that I would make. My sentence would be that they are, by continuing to use the term parental alienation as professionals, they are degrading the quality of professional practices in the family courts, which is inappropriate. They need to step it up and become professionals and use professional terminology, because right now they're destructive and they're harmful, and I got to think about how to address them to a certain extent, except they're irrelevant. I'm just going to let them move aside, and anybody they capture of you parents, you just get captured on that. So the diagnostic checklist and the parenting practices rating scale are over on the mental health consulting side. So if you're looking for those, find those. The other form over there is the parent-child relationship rating scale. That is an excellent outcome measure. I know what I'm doing. People don't think I know what I'm doing. I know what I'm doing. That the parent-child relationship rating scale is excellent. A 1 to 7 scale, 1 and 2 are awful, 6 and 7 is wonderful, 3, 4, 5 is normal range. That's a nice normal curve. And it's daily ratings from the targeted parent sent to the therapist, the family therapist, who puts them in an Excel file and begins to track them All we want is a child to stay normal range 3, 4, 5. If they're down to ones and twos for a long period of time, that's the symptom of the pathology. Um, and so the three items that we rate are on that scale are affection, that's your attachment networks. So 1 to 7 on affection. Cooperation, those are your emotional regulation networks, 1 to 7, one normal range. And social involvement, that's mood and arousal. We don't want the kid to come to visit and hiding out. No, are they normal range social involvement? Rate those three scales, send them into the individual therapist. Now, that puts the therapist then on the spot. You have to fix the pathology. You have to come up with a treatment plan to fix things. We're done with this era of no successful treatment. No, if your treatment's not successful, there's two reasons for it. For treatment not being successful. A, your diagnosis is wrong. You're treating cancer with insulin. Or B, your diagnosis is correct, but you're incompetent in the delivery of the intervention for that diagnosis. If your diagnosis is correct, then your treatment should be effective. If it's not, either you can't do the treatment very well, or your diagnosis is wrong. There's only two possibilities for a failed treatment, and I don't like failed treatment. I'm not accepting failed treatment, and the problem is the diagnosis is wrong. It's child psychological abuse, shared persecutory delusion, and they're not making the diagnosis, so they don't develop a treatment plan to fix it. So we're going to start holding them accountable for effective treatment, and that will expose the fact that they don't know what effective treatment is. Ultimately, they're going to have to learn dialectic behavior therapy. All the therapists in the family courts are, with high conflict custody situations, are going to be working out of a dialectic model, dialectic behavior therapy model, because the CBT component of that, cognitive behavior therapy component of that, is going to be good for challenging the irrational beliefs of the delusion. And you do apply behavioral analysis on the parent-child conflict, and you can identify inauthentic conflict. So the CBT portion of dialectic behavior therapy is going to treat the pathology, and then the mindfulness component is wonderful for that trauma component and the child's stress, and teaching them the skills to bring down that trauma and find their authenticity through the mindfulness. So DBT needs to be over here. Now, the issue with that, though, is dialectic behavior therapy is for the treatment of borderline personalities. It's been adapted to a number of other things, substance abuse, various other, not to the family courts, because nobody works in the family courts. So, but it's going to need to be adapted, because we're not treating the borderline pathology. We're treating the consequences of a narcissistic borderline dark personality on the family. But it's the structure of DBT is going to be useful. Then I'd like to see you pull in Ed Tronick on his breach and repair sequence, and that'll fix up the relationship attachment side to things. So basically, what I'm doing here is I'm coming in and I'm establishing standards, and I'm the floor, not the ceiling. So this is baseline that they have to do, and I'm empowering you, the parents, to hold your mental health people accountable for actual knowledge and actual real things. And if they're not accountable, then do the appropriate thing to elevate the profession, and to address the harm done to the consumer because of ignorant, unethical, incompetent professional practices. We need to improve the quality of services. The mental health services in the family courts should be of the highest caliber, not the lowest. The child's life hangs in the balance of the court's decision. That should merit the highest professional response out of psychology, the highest application of knowledge, and the best both diagnosis and treatment of the pathology. The child deserves it, and the courts deserve it. So just from that alone, Instead, we're getting the lowest because forensic psychology is a failed experiment in service delivery to a vulnerable population. We've had 40 years of trying this experiment of your own special psychologist. It doesn't work. It's destructive of families. The professional practices are at the just non-existent. It's the worst over here. We need to take a step back, professional psychology, reevaluate the situation and how we respond to our risk management obligations, and develop a different approach based on our experience of the last 40 years. We need to get clinical psychology back. We need to start doing diagnoses. We need to start establishing training and education in the domains of relevant knowledge, attachment, personality pathology, complex trauma, family systems therapy, delusional thought disorders in the family courts. So we need to develop the competence in the training, and we need to apply the knowledge to reach an accurate diagnosis and effective treatment plan 100% of the time. My estimate, just from attachment, knowing what I would think of attachment in my stuff, for this type of attachment pathology, I would want a treatment plan. I would expect my treatment plan, or my intern or postdoc, or I would expect the treatment plan to be about 6 weeks to a recovery of the child, and then 6 weeks of stabilization of the child and monitored with a parent-child relationship rating scale. And I would anticipate within the first 2 weeks, I'm going to be seeing substantial gains. And so I'm going to get 80% recovery within the first 2 weeks, and then the next 4 is going to give me the other 20%, and then we stabilize the child out. Now, Dorsey Pruder has a high road workshop, 4 days, full recovery, 100% successful. She's successful with her program, with that workshop. I know the protocol. I've seen the protocol. I know how it works. And I've watched all 4 days of the workshop. I know what it does. I know how it achieves its success. I took her to AFCC, where we explained what it was to all the forensic psychologists. We went to the American Psychological Association and provided data using the parent-child relationship rating scale for a 2-day workshop. She had to modify a little bit. She didn't have time. So a 2-day workshop. She recovered the child from 1s and 2s to 5s and 6s in 2 days. And this was 3 years of child abuse, documented. 3 different psychologists. I've read their reports. 3 different psychologists. One said it was, in his 40 years of practice, it was the worst case of a narcissistic parent he'd ever seen. And so 3 years of documented child abuse, 3 psychologists. She got a full 15-year-old child and a mom. She got full recovery of the child's attachment bonding to the targeted parent in 2 days. 2 days. And I know it was a stable recovery. I know it was a clean recovery because I was the follow-up care therapist for this. That's the only case I've been a follow-up care for a high road. And so I got to do a kind of like a full kind of sweep of the child to see what's going on. Easiest case I ever worked with. Wonderful young man. She got a full recovery in 2 days. So there is an alternative approach to my therapy. It takes 6 weeks, but it's pricey because you're dealing with Dorsey. You got 4 days of Dorsey's time. Is what I meant to say. Is you got 4 days of the top expert in the recovery of children from complex trauma. She's the most experienced professional over here in the recovery. So that's going to have costs associated. I'm pricey when you come to me for my clinical evaluations. We need to bring that cost down, but that means the forensic people need to be going to Dorsey to get training in stuff. And I'd like to see a way of transferring the protocol into the university and healthcare system appropriately. And that would help. But until people are motivated to solve things, nothing gets solved. It's a motivational pathology within forensic psychology. Ignorant, lazy, incompetent, unethical. and it's just the lazy part. Um, Here you have somebody who can solve this pathology in a matter of days, and none of the forensic psychologists are talking with her, consulting with her. That's phenomenal. And so that's part of my history journey here is I've documented. I went with her to AFCC because you guys need to know this information, and I gave the information through the APA on the success of the program. So it's not me, it's not Dorsey, it's you guys who are not motivated to solve anything. And so that's where the licensing board complaints, malpractice lawsuits, you parents holding them accountable will hopefully find their motivation to solve the pathology for all children and all parents now and into the future. So we need to reevaluate things. So I just wanted to hop on board again and give you a little addendum on my consulting website. Get over there and you might find some handouts that are useful to you. I use them in my practice with attorneys I work with and mental health people I work with. But if you're not engaged with me directly, perhaps you can make use of them as well to leverage the fulcrum in your situation as well. So good luck with your kids. We'll talk to you next week. Happy Sunday. Bye bye.